Once again, thank you everybody for joining our webinar, Step 9, and it's going to be presented by our IMBCO board members. They will introduce themselves as they speak. You can tell who is speaking if you click on the participants list at the bottom. But please do mute your microphone so we don't get any outside noise. And we're not doing any video sharing today because there's too many participants. So we will begin now. And we have Sue Down presenting, and Sue is on our board. And as you speak for the first time, Sue, Ellen, and hopefully Mary, and we have Amali with us, please introduce yourself, briefly your background, because you all have so much wonderful experience and so much to offer to this presentation. And this presentation has been a wonderful collaboration. So thank you, and I'll let you begin.
Thank you very much. Sue Down, starting off here, Professor of Midwifery Studies at UCLan, the University of Central Lancashire in the UK. And as Ray says, this has been a combination of lots of different people bringing together this presentation. So we hope it will segue smoothly between one section and the next. But anyway, there's a lot of information here to get through. So this step, as you can see, is about a continuum of collaborative care. That's for the mother and the baby across all relevant health providers, institutions and organisations. And it's important, Helene, could you move it on two slides, the next slide and the one after? And the next one. Sorry, go back one. Yeah, so the second part of this is the expansion on this basic idea. And we've particularly said that it's important that this collaboration includes traditional birth attendants and outside of hospital birth, because we know that in some settings, the use of traditional birth attendants is not necessarily very highly acceptable, and also that out of hospital birth is not highly acceptable. And we're really wanting to make the point here that what's at the centre of the whole enterprise is the mother and the baby, not the way that care is organised politically or economically or for any other particular ideological reason. The important thing is that the mother and the baby get the best possible care that's seamless, so that they don't actually see the spaces between the care that's provided. They just experience a continuum of positive care. And we know that in many countries, women are much more likely to go to traditional birth attendants as skilled birth attendants because they know and trust those individuals. And it's vitally important that we don't marginalise either the women or the care providers in that kind of circumstance. There's a particularly interesting paper based in one of the South American countries, and the title was Burning Bridges. And it was basically making the point that if we don't liaise with the care providers that women choose, we burn the bridges between themselves and central services, such that women will choose not to use our services or not to use centrally provided services for those who are professional providers. So this is not just a luxury, it's actually something vitally important for women and babies. And this leads on to the next slide. As you can see, the next part of the definition, which Helene's just put up, which is about the best possible care. And we can only do this under a criteria of mutual respect, only if there is mutual respect between all care providers for the various skills that they bring and the various knowledge and experience they bring, are we going to get to that particular position. And some of what we want to talk about in this presentation is how we get to that point. Next one, please, Helene. So the other point about this, and this links up with some of the other steps in the baby IMCO 10 steps, which is about continuity of care, particularly carer as far as possible, from a small number of caregivers. So this has been operationalised in some places as case holding, where women are supported by a small number of professional staff. In others, it's been characterised as team midwifery or team care provision. And in others, it's just about making sure that there is a minimum amount of care providers that work with the woman, whether that's a doula, whether that's a midwife, whether that's an obstetrician, so that in her particular case, she doesn't get repetition, that things that happen once, and the information is shared across the small group of people whether the woman is healthy or whether she and or her baby has complications. This should still be true. Consultations and transfers in a timely manner. Now, one of the problems about a lack of collaboration is that either transfers don't happen because people don't want to pass the woman on, because they believe that in doing so the woman will get worse care, or they believe they're going to get paid less, or they believe that the woman won't understand what's happening. So if there's mutual disrespect, the woman and the baby lose out because transfer processes become delayed or sometimes accelerated because care providers don't want to be disciplined for not transferring. So where respectful care is in operation, collaborative processes allow for smooth, efficient and kind care, compassionate transfer of care where it's necessary. And this connects up with the general right care or too much too soon, too little too late agenda that the Lancet various series has been promoting. The other important thing is the community services. This isn't just about collaboration between those who are providing immediate antenatal, intrapartum or postnatal care. It's also about the peripheral and associated community services that women might need. So housing support in cases of domestic violence, support in cases of poverty or lack of food availability, various things that are going to affect the well-being of the mother and baby that are social care, maybe seen as social care, are also caught up in this notion of collaboration so that the mother and baby and family, again, get the best possible start in life, not just something which is totally focused on their physical needs. Next slide, please. So there's been a variety of WHO and PAHO and all the rest of them are quite keen on putting out models and diagrams of various kinds. This one's quite a helpful one, and it ties up with what I've just talked about, which is there are whole levels that matter to women and babies. Again, this won't be a surprise to those on the call. And this particular one talks about the household, the community and outreach, including civil society and health facilities, and the fact that all of these need to be borne in mind when we talk about collaborative care. Next one, please. So collaboration, some definitions of collaboration refer to it as a bad thing, that if you're a collaborator, you're kind of colluding in potential bad quality care. And it could be read that way. So it's important that we define collaboration in this particular way, which is the act of working together with people and or organisations to create or achieve something. And in this case, it's the creation or achievement of a positive maternity care experience for mother and baby. And I think it's quite interesting that if you break the word down, co and labour. So this is about co-labouring together in a way that maximises the benefits for those and also for ourselves. If we're positively collaborating, we're not wasting emotional energy on negativity or on trying to constantly build bridges. If we've got a smooth collaboration, if we're smoothly co-labouring together, then all our efforts can go into promoting positive work environments and positive outcomes for mothers and babies and families and society in the long run. Next slide, please. So this is another kind of report. This is actually a UK report that came out in 2006 when there was a whole load of concern about adverse outcomes, this time in the general patient population, not particularly maternity, but it relates to maternity too. And what this report talked about was 7 particular aspects that need to be engaged with to maximise interprofessional working. So this is the how do you make it work thing. And you can see it's about partnership, it's about making sure that whoever funds services recognises collaboration, it's about formally setting up interagency collaboration, and the one I've highlighted here, interprofessional collaboration and teamwork, that actually at the local level, it's our responsibility to build interprofessional collaboration and teamwork. So although professional education and training is important that we share, and I think the next slide talks about this too, really the fundamental work, the fundamental co-labouring that we all have to do is on our individual relationships at the local level with our professional colleagues or with our doula colleagues or with our skilled birth attendant colleagues and with our local community services. Next slide, please. So I think this is my final slide, and this is another WHO diagram. And basically what it's suggesting is that if you have fragmented healthcare systems, building interprofessional education, and I think Helene will tell you a little bit about how this might have happened in a very local level, can actually create a health workforce that then operates on fragmented health systems to create collaborative practice, which in itself then strengthens healthcare systems and improved outcomes. So even though you might have or might be working in or have colleagues who work in a system which is fragmented, and that can be in high and low income countries and middle income countries, that doesn't prevent the building of collaboration at a very local level, because that in turn has an effect on the total healthcare system over time. So I think that's the end of my slides. Has Mary arrived yet?
I have. Thank you.
Oh, excellent. Okay, I'll hand over to you then, Mary.
Thank you. Thank you, Sue. That was great. Hi, everybody. This is Mary Sagety-Leslie. And so I think we'll take it from here and start looking at some examples of what ways this has been studied and applied. So this first one was an RCT looking at the continuity of care, comparing community-based models with standard hospital care in Australia. And actually, Sue was involved in this, and I'm going to ask you to tell us a little more details. Most importantly, this was care provided by both midwives and obstetricians, and it significantly reduced the cesarean rate. So did you want to?
No, it wasn't this one. It was the next one, I think, or the one after. I'll jump in when it was the one I was thinking about.
Okay, fine. Thank you. Okay, so this is another example, and I looked at this one. So this is another randomized controlled trial, and this took place in Seattle, and the population was mothers receiving federal funding or Medicaid. And so there was a sort of normal form of care, which was what we call expanded care. So it wasn't just healthcare, but it would have had education involved and nutrition and things like that. So it already was a collaborative model. But in this particular study, what they added were mental health professionals as an integrated part of people's care, screening for depression, screening for issues, and basically being an integrated part of the care, rather than something where, you know, we might find somebody we thought could use support and we refer them out and we don't really know too much about what that other provider's thinking, et cetera. So the startling thing with this is they found a significant reduction in postpartum depression and in post-traumatic stress disorder with both. That was a pretty strong statement for what happens when we get together. Next slide, thank you. So addressing the relational components of birth is an essential part of looking at this concept of collaborative care. And I think, you know, some of us are very good at relational communication and being perceptive about relational aspects, especially in the birth room. But we have to expand that and include everybody involved in the mother's care. So parts of that include that it's a known and trusted carer, and this relates back to the concept of as few providers as possible, and ideally that they know who's going to be there when they're in labor, or the person in labor is going to be one of two people, something like that. It involves respectful dialogue and practices. I think that's pretty self-evident. And it requires consensual care. So that, I think, is a critical concept in terms of that everybody needs to be on board with the care model or with the choices that the woman makes. And she needs to have both informed consent and informed refusal options when new things develop or new forms of care are suggested. And well, look at this. And there has to be a tolerance for informed dissent, or what I call informed refusal, which is understanding that it is her call. It is her call that determines her care. And in a collaborative model, everybody has to be on board with that concept. And then provision of information and privacy, that's, I think, very clear. It has to be really well embedded into the system, especially when multiple providers may be involved. So some examples of this are midwifery, sorry, I can't talk, midwifery-led one-to-one model, and there's a Cochrane systemic review about that and showing its impact on care and outcomes. Doula support is another example, and teaming up with traditional birth attendants, as Sue discussed earlier, is another example. So qualities, we like to suggest that qualities of a good collaborator. So I think a good way to look at this is this is about me, it's about you, and what we can bring to it, and then what we want to see in our partners. So
Mary,
approachable.
Sorry, Mary.
Yes,
this
go ahead.
came out of our research. Do you want me to tell you a bit about the background first, then you can go on to talking about the elements?
Go ahead.
Okay, so this emerged out of a study that we did with obstetricians and midwives, and in fact service users, where we were about to set up a birth centre, an out of hospital, a freestanding birth centre in our local environment. And we wanted to find out, before we did that, how we could maximise optimal collaboration between all the parties, so that we didn't have women being stuck in the birth centre and not being transferred when they should be, or being transferred too early, or having kind of different tribes being set up. And so we did a range of things, and these criteria actually came out of that consultation exercise. And in fact, now we have, in that particular area, we have 1/3 of all the women having their babies outside of hospital. So either in a alongside birth centre, or a freestanding birth centre, or at home. And there's incredibly good collaboration between all concerned in that particular place. And Mary, I think you're going to go through a list, which is fine, but I think that's really important. But the one thing I want to just highlight here, well, two things. One is risk takers. So what the respondents said is it was important that good collaborators took risks to maximise collaboration. They didn't just go along with the system. They actually, if something was needed for a woman, or if various parties needed to do something unusual, then they stuck their necks out and supported them in doing that. And the other thing I wanted to particularly pick out was influence people by the little things they do. And what people talked about was senior staff taking care of juniors, and noticing when junior staff needed a rest and taking care of them, or making tea for them, or everyone just having tea and cake together every now and again. And those things really stood out. But then, so Mary, can I hand back to you to go through the list as a whole?
I'm happy to, Sue, but it'd be great to hear you, since you're so connected to where these came from. Would you mind taking us through it?
No, that's fine. Okay, this is just to show this is a collaborative presentation, everybody. Well, I mean, I suppose most of it is fairly self-evident. It's the kind of things that I think we would all talk about. We've already talked about, I mean, approachable experience, valuing others, offering constructive feedback. That's actually quite important, number 4, because it recognises that we don't always get it right. So that in a collaborative relationship, it's not about saying, oh, everyone's lovely, everything's fine. It's about saying, you know, what you did then was really good, and this is why it was good. But also, what you did then you might want to think about that a bit more, and this is what I would suggest. So it's both being really constructively positive and constructively negative, if you like. Willing to share ideas, that was also important, that if people had good ideas, they didn't keep it to themselves. And drawing positives out of bad situations was about moving away from the blame culture. So rather than saying, oh, it's all the midwife's fault, or it's all the doctor's fault, or it's that individual's fault, or it's the doula's fault, it was about saying, when something goes wrong, let's all sit together and work out how we could do it better next time. But equally, it was about saying, when we've got a good outcome in a situation that was really, problematic, let's also congratulate all of ourselves on a good job well done. And then finally, having insights into themselves was about building a culture where people are consciously and constantly reflexive, just so that, again, we don't get stuck in standard ways of thinking and operating, that we move beyond that. And in fact, one of the obstetricians, the phrase that I kind of remember from this is, she said, we have to get beyond the gargantuan struggle, by which she meant we have to get beyond the midwives versus obstetrician struggle. But of course, it could be, you could substitute doulas or TBAs or anything in that particular mix. But I think it was a very good summation of what this particular project was working towards.
Thank you. I wanted to just add to what this all makes me think of, but 2 of my favorite resources for the area of communication is an older book called Getting to Yes, written by people who negotiated on behalf of countries, talking about how they did that. And a more recent book, which probably several have heard about, but if you haven't, it's excellent, called Crucial Conversations. And I think it's important to, along the lines of self-reflection, to realize, we don't sort of know everything. And sometimes we're going to have to build new skills in order to build new collaborations. So barriers to looking at multidisciplinary collaborative care. One would be interdisciplinary rivalry, and that can have all sorts of kind of sources behind it. One's turf protection, one can be monetary, and it can result in a lack of mutual respect. And it's important to understand the barriers in your particular setting. So these are broad generalizations, but you will find out certain barriers that are very specific to your area, and it's important to include that in your initial assessment of improving care. And then there are structural barriers having to do with fee structures, liability, and insurance. And I've experienced sometimes a lot of barriers actually coming from the institution or even the insurance companies. So, while we may want to improve our care by being more collaborative, sometimes the system is not designed for that necessarily. Not to give up, though. So solution is strong leadership and education. And I thought I'd just say a word about education, which is there's a pretty large movement right now towards interprofessional education models. And the concept is that while they're in the learning phase, students are going to become doctors, students who are going to become midwives, students who are going to become physical therapists. I mean, any of those areas that they begin learning together, and they learn about especially normal birth together. And the initial studies looking at this have found it really alters the culture, and it makes sense to me that it does. It alters the culture when we learn together, and that's a strong foundation for this. Thanks. Go ahead. Okay. So in the U.S., the American College of Obstetricians and Gynecologists and the American College of Nurse Midwives got together on a project about models of collaborative care. And I can even say long ago, they got together and came up with a statement called the collaborative model of care that defined how physicians and midwives were going to work together. And that's been around for a long time. So they identified in this more recent work, they identified factors that involve the successful and sustainable collaborative practices between obstetricians and midwives. And so number one was that there was an impetus for new collaboration. And I think that's pretty clear. We've got to identify a motivation and an impetus. And I think we have to look at it on all levels, not just individuals, but professional and institutional. Then the second one was that they have the basic foundations of collaborative care. And how I look at that is sort of assessing the environment and the openness and the access to resources to make this happen. And then once started, you have to have a commitment to a successful partnership. Everybody ideally is on the same page about where this is going and what the goal is. And sometimes I find that we don't all have the same exact goals, and I don't think that's a problem, but we should identify our mutual goals, and we can continue to have our personal goals too. And then the integration of care, and of course that's easier to say than do, but the concept is that the model already has the integration there. So in my mind, we kind of shift from I'm a midwife and I will consult, or I'm a midwife and I will refer to my physician colleagues, that we develop models where it's integrated from the beginning and the patient has a relationship to all potential caregivers. And then the last one is that health professions education, what I just spoke about, exists in an interprofessional practice environment. So expanding a little beyond the idea that classes in school might be shared, integration in a clinical setting provides the opportunity for interprofessional care too. Okay, I think that's it for me.
Okay, yeah. Hello. This is Hélène Vadeboncoeur. Do you hear me?
Yes.
Okay, good. I'm a researcher in childbirth from Canada. I'm the author of a book on VBAC, vaginal birth after cesarean. And also, apart from being on IMBCI board, I'm part of the Respectful Maternity Care Advisory Council that created a charter on universal rights for women around childbirth. So I'm going to talk about the implementation of IMBCI in a collaborative way in Canada, in Quebec, this is a hospital in a rural, semi-rural area, and it has always been a progressive one, avant-garde. And so in 1999, it became the first baby-friendly hospital in Canada, and it remained so for quite a while. The hospital was a recertificate in 2004, and then the certification extended to community, local health and social services clinics, and also to the whole organization above the hospital and the CLSCs. So it really became, expanded in the whole system. So that facility, where there's about 900 births a year, it's an obstetrical department in a small hospital, 80 beds total, not for birth, but total. And in it, you find 10 bedrooms, including bathroom, hide-a-bed, lunch corner. And in these rooms, the woman is in active labor and gives birth, and then spends up to 48 hours in postpartum there before going back home. And there's 2 pediatric rooms, because it's also a place for pediatry to happen in this level of hospital. There's an ambulatory exam room, and there's a newborn observation room, but there's no delivery room, only for giving birth, no, and no nursery. So it's kind of the unique concept of the rooms. And so for the implementation, the site was accepted by IMBCO as a demonstration site, potential demonstration site, in 2009 at the end of the year. And it started to prepare for implementation in 2010. And it started, or 2011, and it did implement it became fully implemented in 2013. So the first thing was to create a committee where people would work. And so there were 2 nurses from the birthing center, 1 family physician, because family physicians are the main responsible in that hospital for the births. There are OBGYNs, but who come only in case of complications, and there's no midwives on the premises, because in Quebec, midwives are since they've been legalized, they practice mainly from a birth center independent, with no doctor on the premises, but they can help the woman have a baby at home or in the birth center or in some hospitals. And you had also in that committee the head nurse, who is the chief of program for the birthing center and the community services in care and infancy, perinatal care. So that committee was created, and they started working on the preparation of the implementation of IMBCI. So in addition to that core committee, there was some nurses from the birthing center, a nurse and lactation consultant for community that has a special role for vulnerable groups, and nurses providing prenatal group classes. So the first thing was to identify what steps they needed to work on. And since that was already very good hospital, respecting women, and and baby friendly and all that, they realized that they consulted with doctors and nurses in order to identify what steps needed to be implemented. And the answer was step 2. They really needed to improve that aspect of their care, start to look at midwifery knowledge and skills that optimize the normal physiology of birth and breastfeeding. So that was their focus for implementing IMBCI. So what they started to do is to, these committees started to read books on physiology and normalcy of birth and labor and birth, evidence-based, like the book of Sue, who talked at the beginning of this presentation, and Dennis Walsh and Verda Schmidt, and mostly midwives. And they hired a midwife, although there was no midwife on the premises. They hired a pioneer midwife in Quebec, whose task was to write a common knowledge document on physiology of birth and normalcy of birth and evidence-based that had to be read by all caregivers and managers. And by caregivers, I mean doctors too, not only nurses, but doctors, nurses, managers. And they devised a training that would be done by a multidisciplinary team. And so a doctor who is the head of the More OB SOGC program of the Society of Obstetricians and Gynecologists of Canada, Guy Paul Gagné, and nurses from the birth center, and a midwife who was a coordinator of a birth center, and the manager that led the whole implementation from beginning to end. So this was the team for training. So what they did also is a global and in-depth revision of the prenatal courses. So not only the content of the courses, but also they decided to change, the way they were, like to offer it during weekends or in 1 day or 2 days, and not only the traditional once an evening program, because they realized that, life being what it is, the new generations had new needs, and so they did that. And also, it's not only a matter of the hospital personnel to learn about IMBCI, but they had to, not train, but inform all other institutions linked with services to prenatal childbearing and new mothers. And yes, CLSCs, community health clinics, but also, with the old age homes, because grandparents can help support breastfeeding also. So it's a whole community that got informed about IMBCI like they did for Baby Friendly. So it's a global effort. And they obtained the commitment of all the personnel, doctors, nurses, and auxiliary personnel, I don't quite know the name in English, by putting an emphasis on common motivations. And so after implementing IMBCI, they received an award from the Society of Obstetricians and Gynecologists of Canada for its implementation. And its implementation was greatly enforced by the program More OB, that is a multidisciplinary program where, in the training and in the practices, and then everybody is on an equal level. A nurse can do an emergency procedure because it's on safety. This program originally is on safety of birth. And whoever is present needs to have all the skills and the practice in order to react properly. So it was on that model, plus the training was done also by people from different healthcare professions. So it received that award, and it also presented IMBCI and its implementation at conferences. So, in terms of collaboration, it was really successful. It doesn't mean there was no obstacles, but for instance, OBGYNs sometimes may have more hesitations, but they managed to get people on board, and they devised, things to evaluation means to evaluate if they were complying with the IMBCI steps. And when I see there was a slide by Mary, one of the last slides, on the 5 teams that you find in collaborative care, and when I looked at it, I say, wow, that's really, the impetus of the change, the collaborative care change, was IMBCI. And the basic foundation, yes, criteria, yes, and the commitment yes, there was a huge commitment to achieve that in that hospital, and I accompanied them as a member of the board because mainly because it's in Quebec in French, and I happily live 15 minutes from there, so it went really well, and care integration was already happening since the More OB program had been, it's a 3-year program for hospitals. So it was already, becoming part of how they were doing things. And interprofessional education and practice environment, well, that's what they did for the implementation of IMBCI. So I was happy to see that it worked that way. So it's not, it's a lot of work. It took them, a good 2 years to prepare, and because there was no special money set aside for that. They had to do it within their regular budget and time, and the manager Christiane Charret put a lot of hours over the top of what she was of her full workload. And but it did happen, and it's very encouraging to see something. And I happily, had the chance to see my first granddaughter be born there. But it was before the implementation, and even before the implementation, things were quite nice. But what I had noticed is that physiology of labor was not exactly what was happening. But I'm sure that since then, and satisfaction of the clientele has not necessarily improved, because it was already quite high, but there were more comments. They ask the clientele to write before they leave the facility to answer a questionnaire, and there were a lot of positive comments, and especially from the fathers. The fathers seems to have enjoyed the new prenatal classes a lot. They could understand, why things were going to be done that way, within a physiological approach, and especially the men were quite, because they understood, and then it was a lot easier during the birth. Anyway, it went well. So I think, and yes, Canada is a country that has some money, but there's been a lot of cuts in the healthcare system in the last years. So there was not a ton of money, but it can be done. The will to do it is the basic ingredient. Thank you very much.
Thank you, Helen.
Whoops.
Oops.
Sorry. I'm going to go back to where I was. Okay.
There we go. And then with each click on this particular slide, Helen, the points will be made. And is this where Amali comes in, or Sue?
Yes.
Okay.
Amali.
Amali.
If Sue could go over this slide, I'll take over with the next slide.
Okay. So.
Well, okay. So I have to do that. Sorry.
Okay.
Okay.
Oh, now you have to go back to it.
So do you want the full slide, this one?
Yeah.
Or the next one?
This one.
Okay.
Is that for you, Sue? Sue?
Hi. I can hear you, but I'm missing the slides.
Yeah.
So maybe we should just move on to your ones, Amali, because I know time's a bit short.
Okay, I'll just briefly talk about the sort of facilitating factors for the change process. I work in an environment where there is very good collaborative partnership between midwives and obstetricians, but doulas are not integrated into the NHS system. So there can, in any situation, be problems. but really you need to recognize the need for collaboration and encourage each other to do it. And you've seen a really good example with in Quebec. We really need sort of the support of all the levels of the hierarchy, and leadership from them. And as demonstrated by the previous example, the plan in Quebec was quite analytical, and there was good buy-in and a common vision, and they achieved very great gains in looking at collaborative change and looking at the IMBCI steps. So if we can go on to the next slide, Hélène. So I've been tasked with summarizing. We've seen in the presentation that there is an evidence base for collaborative care in maternity, that when you do this, you deliver much better maternity care and reduce the risks and optimize outcomes. And women enjoy their care because they feel that it's joined up, and that there is no rivalry or animosity between types of care providers. And really, if a centre is looking at this presentation and looking to improve collaboration, there are lots of effective models and resources that you can look at, but there is no one right way. Each geographical location with its own economics and politics and hierarchies would probably have to make a bespoke solution for themselves, but start where the situation is and persevere and build from there. Hélène, could you move on to the next slide?
Yeah.
So really,
sorry, Amali, this is Ray. I want you to introduce yourself as you are summing up this so beautifully, as your background and experience lends a lot to this presentation.
Yes, of course. Forgive me, I didn't introduce myself. I'm Marley Lockigam-Gay. I'm a consultant obstetrician and gynecologist working in the United Kingdom at a London National Health Service hospital. And I'm also a medical educator at University College London Medical School. So really, coming back to this summing up slide, you've seen in this presentation that we have shown you the evidence base behind the worth of collaborating in maternity care. And we've also looked at some of the psychological factors involved with collaboration and really kind of rooting out positive behaviors that need to be encouraged. And although collaboration has been seen to be easy in some of the examples, of course you're going to be dealing with various personalities. It can be difficult, and so therefore we really have to stress the fact that all communication and collaboration has to be respectful. We have to build trust between groups. We have to center on the shared vision and have that willingness to work together and work things out. And of course, there can be dust in the kind of machinery and grit in the machinery of collaboration. But when you get to those obstacles, expend patience and perseverance, and the projects can endure. And you know, finally, implementing the IMBCI steps with this framework really does work well, and we've shown you a good example in Quebec. So next slide. I'm going to thank you all for joining this webinar, and I believe the next presenter is actually listening into this talk. So the next webinar, which will be Step 10, which will be presented by Fiona Dykes on May the 8th, 2007 at 3 p.m. EST, and that is on striving to achieve the 10 steps for successful breastfeeding as described by the WHO UNICEF Baby Friendly Hospital Initiative. And I wonder whether Fiona would like to make some comments at this stage, because I can see she's logged on to this webinar. Fiona, are you there? You can unmute your microphone and join us if you'd like to at this moment in time.
Fiona, you are unmuted. And it may very well be that she had to step away, Amali.
Yes.
So, in any case, it will be a wonderful presentation because she really presents some really good questions about the importance of the initiative and how to implement it. So thank you so much. And Kathy Hirschderver is also on our webinar today, and Kathy was instrumental in bringing this together as well. So Kathy, did you want to add something to this?
I'm unmuted. No, thank you, Ray, and thank you all my fellow board members. It was a wonderful presentation.
Thank you, Kathy. Well, again, this is Ray Davies on behalf of Deborah Pascali-Bonero, and I'd like to ask maybe one more time if Alain, Mary, or Sue, or Amali have anything additional to add, and or if any of the other participants have some questions, we can take a few moments to answer them for you. You can type a question or unmute yourself and ask.
Hi, this is Julie Bonapace from Quebec. Thank you for the great presentation. I was wondering if Hélène could send, or if she could give the information concerning the normal childbirth document that was prepared by the midwife in Coensville.
Okay. Well, I'll ask. I just don't know, you know, if I'll ask the permission, but I don't have it, and so I can't promise it, but I will. So, Julie.
Okay, thanks.
Well, unless we have more questions. Oh, Fiona was saying here she was having difficulty with her microphone. So we'll have to work on that, Fiona, for the webinar next time.
Ray,
Yes.
Ray, I'd just like to chip in. This is Amali Lokugamage speaking. As a medical educator, I'm really quite passionate about the fact that we need to develop interprofessional learning. And really what we need to do is encourage this from the levels of the colleges of midwifery, the colleges of obstetrics and gynecology, and other such professional organizations, depending on who is there to collaborate. It's really, really important. And we've stressed this, stressed that it should happen obviously at a local level, but it would be wonderful if it could be done from an international level. I don't know how people feel about that.
Well, I think it sounds great to me, Amali. And in a way, if you think about it, our wonderful 10 webinars, or as of May 8th, 10 webinars, is a good example of that education across the globe.
Ray, this is Kathy. I'd like to step in for a moment and speak to what Amali said. Is that okay?
Go ahead, Kathy. Thank you.
Yeah, Amali, thanks for that. I really agree with you as well. And it made me think of some of the work we did at the beginning of that multi-collaboration project in Canada, which we presented some of the results. But for that project, I worked with a few people to put together some information about different systems of midwifery and medical education and how they differed between countries in Europe and Australia, and the Canadians used that. And really, it came back to what we know always, is that the very beginning is that the different players didn't know what they did. They didn't understand their own separate areas of work. They didn't understand what the principles, the values were from each medical or each professional organization. And if you put that together, people really, it's about understanding each other and respecting each other. So I think since then you've seen some cases in which it's happened. I know in France, for a very, very long time, you had people going to the university and starting off with basic medical education and then splitting off into midwifery or into dentistry or into medicine or whatever. And that seemed to have worked for a while. And I do recall, and I'm not sure, maybe there's someone from Canada who can corroborate this, is that in British Columbia for years and years and years, you did have combined medical education between midwives and obstetricians. And I don't know if that's still happening. But the last thing I wanted to add about that is that many, many lower resource and middle resource countries, although you don't have that in the educational system, you do see a lot of quote, professional education in terms of emergency care courses that are being given. And they seem to have worked very well. So there's lots of little things going on around the world in which the different professions or the different groups are learning together, and I think it's something that should keep growing. But in terms of a really established international system for that, I think the systems are so different, it might be really difficult, but as a vision and as an aim, it should probably be incorporated. So thanks for bringing that up, Amali.
Yeah, I would like to give an answer to that. I don't know about BC and in Canada, they're still doing it, but the MORE OB program is a multidisciplinary learning program, training program. So, and I think they may have started expanding the program outside of Canada. So it's something to investigate.
Can I just say that speaking as an obstetrician and sort of medical educator, that the time allocated to learning about physiology of labour and birth is quite small in the entire curriculum of the medical school, as we have to learn about all sorts of diseases and conditions. So often in medical schools around the world, a more technical view of birth is what a lot of medics take away with them. So it may also be worth a targeted system of or some kind of sessional teaching which really looks at the physiology of birth and all of the aspects that we are talking about in the IMBCI as a kind of postgraduate thing for medical schools throughout the world. I think there are good examples, obviously, in Canada of multi-professional teaching, but I, for instance, know that a lot of students in Britain sometimes don't see a normal delivery during their education, and so that depletes the clinical experience that they can draw upon. Anyway, I'll finish there, but I do think targeted education is warranted, actually, especially for medical schools, I would say.
I just wanted to add something to that. This is Julie. I work a lot in France, and in France, the first year is combined for medical students, all medical students, and then they choose from year 2, depending on who's admitted, they can choose to be a doctor or a midwife. The thing is that all of the program is based on complications, on pathologies, on preventing disease, but not really on physiology. So I really believe that in the year that they have in common, they should have a program, at least, for example, on non-pharmacological measures to support women in labor. They don't have a course, not even during the whole course of midwifery. And I sometimes give that course a 3-4 day training in schools. So I think that it's really important that both for all of healthcare providers that they be exposed to physiology and not just complications.
Agreed.
This is Mary. I just wanted, I just think what everybody's saying is so great. I just wanted to chime in from a change perspective. That it seems to me what we're really talking about is altering a culture. And I think that's one of the best ways to do that is to start with people at the entrance to the culture. And that's, you know, that's this concept of interdisciplinary. And it's, I don't know if I need to say this, but it's not just physicians. There's a lot of different feelings by different providers about each other, and whatever we can do to address that, I think is important. I think the harder part is, in some ways, is building this kind of collaboration among experienced providers who've been out and practicing for a long time in one particular type of culture. And one of the things I was thinking about that is that there's a lot of respect for peers within the same profession. So, you know, I might give more credence to something I've been told by a fellow midwife than I necessarily would by a different profession. And so I think the bigger job is going to be having collaborative care as a optimal form of care get embedded in the different cultures. And to do that, you need, you know, opinion leaders and thought leaders that are well listened to within the cultures. Thanks.
Would anybody else from our esteemed board of directors like to add anything else? This has been so wonderful. The collaboration between all of you is impressive. Well, it's been an hour. Unless someone has something else to add, this is Ray Davies on behalf of Deborah Pascali-Panero. I will end this webinar. Thank you.